All right, so number two, we're going to look at chest trauma. So there's a little bit to talk about, but one of the bigger things that we'll see is that we call is a pulmonary contusion. So when we really want to know what's going on, that helps us with our pathophysiology. So if you looking at this and you can see the left lung where it's kind of shaded over there, this is that blunt force or direct trauma, usually a car accident, falling off a ladder, jet skiing. What are they doing? But what happens then is we get that inflammatory response that we talked about in semester 3. So we get a lot of swelling in there, um, histamine response. We could have some bleeding in there, definitely some bruising internally, might even see it all the way through. But what can happen with this, if it's bad enough, it can actually bleed in or around the alveoli. In these pulmonary contusions is a major complication of ARDS. So when you learn about ARDS next week, you may hear about pulmonary contusions being the cause. So again, when we're recognizing and analyzing those cues, they will do a chest x-ray that's going to give them that quick, see what's going on in there. If they need to, they will do a CT scan looking for much more depth, looking for contusions and fractures or fluid buildup. That's where they're going to look for more of that severe injury. The chest x-ray will be great if there's a broken bone, but that CT scan will get us into those tissues. They might do some pulmonary function tests. We may have an absent or decreased breath sounds, especially if those alveoli are filled with the inflammatory process and fluid, or if they have some blood in there. They're definitely going to say it hurts. And so think about what happens if they're not coughing and deep breathing. Those other alveoli are more at risk for trouble. They might be tachycardic. They might be tachypnic. So what's their baseline? Who are they? So really watching and analyzing the respiratory status. And with the contusions, especially with a fall or a car accident, you might only see it on one side. So that is why it is so important that you are really comparing what you hear in both lungs, that you really are doing a complete lung assessment where you're listening at every segment you're supposed to be listening at. So, if they're bleeding, we may be giving them fluids, blood. You put the good lung down if they're side lying. And, I do believe we have put a video in there for you, but we will give them high flow oxygen, which this can go up to 15 liters. Definitely, if you look at this chest, we know we want them in a nice high Fowler's position. Okay, we want to improve lung expansion to every lobe, the good lobes, the bad lobes. So we want them in that nice high Fowler's position. We may need to put them or give them some extra PEEP, which is positive end expiratory pressure. We may have to do this by ventilator if it's bad enough, if they just don't have enough that we can do. So again, that will be totally independent of the type of contusion, how big the contusion is, how much of the lung or lungs are involved. Rib fractures, as I stated, this will show right up on x-ray for us quickly. But when we're recognizing and analyzing our cues, it's very painful. They could be fine. Maybe they had that chest x-ray and it looked good, but they coughed hard enough, they actually cracked a rib and they can even puncture a lung. Could be from the trauma. But the chest is usually not splinted. If it's uncomplicated, it should, what they call, reunite spontaneously. The goal for us then is to decrease pain. We want to maintain that gas exchange, evaluating those outcomes by looking at their respiratory rate, their pain status, their O2 sats. And what also we need to be looking at, making sure they don't develop atelectasis. They could develop pneumonia because, again, that is our job. Are they still coughing and deep breathing? Are we encouraging splinting? Are we ambulating them? Are we doing all the things and not just saying, I'll do it later, it hurts? What are we doing for them? Another type of chest trauma that we see is a flailed chest. We do have one of the mannequins that can actually show us this, but what this is two or three more adjacent ribs. It's a paradoxical chest wall movement where it actually moves inward during inspiration, then outward. And this little video shows it so cool. It's like you put your hand on it. It's just the strangest feeling. We can cause a flail chest from doing CPR. And we were in clinical this week, and I have no doubt that man ended up with some type of trauma and he lived, but from the compressions that were going on. Splinting again is not good. The more we splint, the more that takes away from good chest expansion that we have. But it is a paradoxical chest movement. So let's take a look at this picture to go, Lynn-Meyer, what are you talking about? A paradoxical chest movement. So this is it. It really is kind of cool, but it's not good for them. They're going to be very dyspneic, cyanotic, tachycardic, very hypotensive. So again, it is a paradoxical chest wall movement, dyspnea, cyanosis, tachycardia, hypotension. It's a medical emergency. So treat their anxiety, treat their pain, promote lung expansion by coughing and deep breathing. We will definitely be doing ABGs. We are going to be doing humidified oxygen. If they are extremely hypoxic or hypercarbic, we may need to mechanically vent them again with positive and expiratory pressure or PEEP. In extreme cases, they will do surgery. These clients are at risk for shock. So this is nothing to mess around with, but it is so obvious. And that is why doing a chest assessment visually is so important. You know, are they rising symmetrically? You put your hands on them. What do you feel? Because with this paradoxical motion, you can actually feel it under your hands. Okay, and the last thing that we're going to talk about is who really needs the chest tubes. So you can have a pneumothorax, meaning just air in the lung. So if you look at this first one on the left, you can see, sure you can. It's really hard to see a white mouse on a white screen. I apologize. All right, I'm red. Okay, so this is air. And as you can see, the lung is now collapsing. And this is why we place that chest tube. We're trying to create a negative pressure within this space here, that space, to re-expand the lung. A hemothorax, which that kid kind of had, but the ED doc was okay. to get out 1,200 mils, which think about that. Think of how compressed, he didn't have a collapsed lung. His blood was in here. Well, he did have a collapsed lung. But once she removed the blood in that video, then that lung was able to re-expand. And she did not leave a chest tube in. And that's why he was coughing. That lung was starting to re-expand. You have some clients that will have what's called a hemopneumo. And these clients often have two chest tubes in. And it is not uncommon on a general respiratory floor. I've seen them on medical floors that you are going to see a chest tube, one for the air and another one in a lower lobe to drain the blood. So pneumo means air, hemo means blood, a hemopneumo means they have both. Your cues, you are going to have reduced or absent breath sounds on the affected side. Makes sense to me. If you don't have the alveoli over there, you can't hear what's going on. As far as taking action, if it is small, they'll leave it alone. The case of the kid with the thoracentesis, they just drained him. Or this is where the chest tubes come in. The last thing I'm going to show you here is what is considered a medical emergency, and this is called a tension pneumothorax. So if you look on the left here in this healthy lung, you have a little bleb that's ruptured in there, but everything looks fine. But as that lung collapses, okay, here's my cursor. As this lung collapses here, notice it is now putting pressure on the heart and it's having a mediastinal shift. So as you evaluate the patient, you will see the mediastinum moving to the side. It is also now you have a collapsed one on lung side, and now your heart can't pump as effectively as it did, and it's pressing on the other lung. So a severe deviation of that trachea from midline towards the unaffected side. So in this case, it is the right lung that was collapsed. It is putting pressure on the heart and is now putting pressure in that left lung. They are in extreme respiratory distress. They become very cyanotic. They will have distended neck veins, a real dull sound. This is a medical emergency. Get your team there now, like the rapid. You pray this happened in the ED and not on the floor. Again, it is a medical emergency. They will tap actually a needle in to like let the air escape, and then the client will get a chest tube, and then we will monitor the chest tube from there. So those are your chest traumas. And that is what I have for you today.